Welcome to Afaxys Candid Conversations in Public Health, a new podcast series from Afaxys, a public benefit corporation serving public health clinicians and their patients. Join us as we head to the front lines of sexual and reproductive health care, bringing you timely discussions with leading experts who are shaping the future of public health.
Okay, good morning and welcome to Candid Conversations in Public Health, an Afaxys-sponsored program developed to bring together leading experts in the field of sexual and reproductive health to discuss relevant topics of importance to the public health community. Our topic for today, which is the fourth in our series of 10 podcasts, is titled On the Front Lines of Bacterial Vaginosis Treatment, Updated ACOG Partner Treatment Recommendations. Today will be a terrific opportunity to learn from our experts on some hot-off-the-press, updated ACOG partner treatment recommendations, in addition to a discussion on why the vaginal microbiome is a central focus in this arena. This episode number 4 is a follow-on to our last episode regarding BV prevention with Dr. Christina Muzny, in which we focused on the data from the Australian partner study of bacterial vaginosis. At the time of our last podcast with Dr. Muzny, the updated ACOG clinical practice guidelines had not been published. However, since that time, ACOG has issued a practice recommendation, and we will today be discussing these new guidelines or suggested practice update for recurrent BV prevention. So if you're tuning in today and have not listened to episode 3 of Candid Conversations, I would encourage you to double back and listen to that episode. I'm Dr. Beth Atias, and it is my pleasure to be moderating today's conversation, which I know is going to be both robust and dynamic. I'm joined today, as always, by Dr. Kristen Feldman, who's Vice President of Medical Affairs at Afaxys, and our expert guests, Dr. Ina Park and Dr. Craig Cohen. Dr. Park is a professor in the Department of Family and Community Medicine and the Department of Obstetrics and Gynecology at the University of California, San Francisco School of Medicine. She currently serves as the principal investigator at the California Prevention Training Center and medical consultant for the Centers for Disease Control and Prevention, CDC, Division of STD Prevention. Ina was a co-author of the 2021 and forthcoming 2026 CDC STI Treatment Guidelines. She is also the author of a wonderfully knowledgeable and entertaining book called Strange Bedfellows: Adventures in the Science, History, and Surprising Secrets of STDs. You would not think that anyone could make STDs entertaining, but indeed she has. Her book is utterly amazing and an incredible amalgamation of history, science, and real-world practical wisdom. If you have not read it, you should. I listened to this on Audible Audio, I'll be honest, and loved that you were the author-reader, so it made it truly extra special. Dr. Cohen is a professor in the UCSF Department of Obstetrics, Gynecology, and Reproductive Sciences, and an attending physician at San Francisco General Hospital. From 2016 to 2022, he was the co-director of the University of California Global Health Institute. He has spent his career with a passion and focus in the arena of sexually transmitted infections, including HIV, BV, and HPV, and is forging the frontier of the vaginal microbiome, one of my favorite arenas. His work has been instrumental in paving the way forward for a greater understanding of the pathogenesis in each of these arenas, and he is now extending that understanding of the vaginal microbiome and its implications into other areas such as preterm birth. He is broadcasting with us from the Karolinska Institute in Sweden today, where he is a visiting professor, so we feel super fortunate to have him with us, and thank you for accommodating the U.S. time zone. Dr. Cohen has been at the forefront of the important work conducted in this BV arena, so his insights are going to be incredibly important. So good morning to all of you. We're delighted to have both of you, all three of you, join us today. And thank you so very much in advance for sharing your expert insights and perspectives. Before we begin, do either of you, Dr. Cohen and Park, have any relevant disclosures?
I do not.
I do. So I'm a scientific committee for OCEL and also for EVI Incorporated as well. EVI is engaged in diagnostics around the vaginal microbiome, and O-cell development of live biotherapeutic products for the treatment of recurrent BV.
Great. Thank you so much. So we did review your bios, but I also wanted, to ask each of you if you'd like to, add any information about your background, the work that you do, and maybe anything about some of the work in which you're currently engaged and I'm sure very excited about. Dr. Cohen, would you like to go first?
Of course. I mean, a lot is in my CV, of course. And I'll maybe just highlight how did I get interested in the vaginal microbiome? So it was actually when I was an intern. I was an intern in the Department of OBGYN at the University of Washington, and where a lot of the sentinel work around BV has been and still is conducted. And one of my clinical faculty members is Dr. David Eschenbach, who later on became the chair of the department. At the time was the head of gynecology, of the division of gynecology. And I remember as an intern, in clinic, taking care of patients, this is what we do. And he showed me how to evaluate a woman who came in with an abnormal vaginal discharge. We went through talking with her. We went through talking about etiology, pathogenesis, and all sorts of things. He's extremely knowledgeable and caring clinician researcher. And then going through the microscopy and learning how to identify clue cells and so forth. And it ended up being my first patient that I diagnosed with the condition of BV. And it really instilled in me kind of this interest in taking care of this very common condition that we still knew very little about, and we treated with metronidazole. And it's interesting, 30 plus years later, we pretty much take care of her the same way that I did 30 plus years ago.
It's true. So kind of sad.
It's kind of sad. Yeah. I mean, okay, now perhaps we'll talk about the treatment of the male sexual partners as a way to prevent recurrence. But we really, the field hasn't evolved. And so it's really provide kind of the fuel for a lot of the work that I do and continue to do. And, one of the issues has been there's just a lack of investment. There's been government investment, but a lack of especially private investment, pharmaceutical industry to really develop new therapeutics in the field, which is really slowing down the progress that we could make if we had more resources.
Great. Thank you. Thank you for sharing that. And Dr. Park, how about from your perspective, interesting research and journey?
Sure. So I have to say I'm a visitor to these lands because most of my research has actually been in syphilis diagnostics. But, to dovetail on Craig's point, when we talk about funding and sort of prioritization, I would have to say that in general, STIs or STDs are not a huge priority. Do you know what I mean? For funding, we've always been sort of scrappy and sort of a redheaded stepchild to HIV, which is quite well funded. But, to that note, I've been in public health for my entire career as both a state contractor and now as a federal contractor. And so, as Craig mentioned, this is such an enormous public health issue. And my interest in it, though, is primarily as a clinician, which is seeing patients with BV. And I agree with Craig. It's really exhilarating to diagnose your first case of BV and to know that you can do it with your own eyes. But I will just have to say that Craig would probably agree the deep levels of frustration and desperation that our patients experience because recurrent BV is so common got me very interested in the vaginal microbiome. So when I was writing my book, took a very deep dive into all of the ways that the vaginal microbiome can go awry and the fact that some people really have quite resilient microbiomes and can handle all sorts of stressors from the environment, such as menstrual blood and semen, et cetera. And some people get tipped over into BV so easily. And I'm just very interested, both as a clinician and as someone who writes STI guidelines, as to why that is.
Interesting. Great. Thank you for that. And Dr. Kristen Feldman, could you also introduce yourself and share a little bit about Afaxys for our listeners who might not be familiar with the work that Afaxys does and the customers which it serves in the public health setting?
Thank you, Beth. My name is Kristen Feldman. I am a practicing gynecologist, and I'm the Vice President of Medical Affairs at Afaxys. We are a public benefit corporation, and we serve public health clinicians and their patients in sexual and reproductive health care. We have 3 different arms in the company: a drug development arm, a portfolio of generic, oral, and emergency contraceptives, as well as our group purchasing organization. And I'm really proud to be working for a company that is such a champion of public health clinicians and their patients. And
Great.
although we've experienced the same issues as a clinician as Doctors Cohen and Park, in that I too see plenty of frustrated patients with bacterial vaginosis and recurrent bacterial vaginosis. So this is clinically a very important topic for me as well.
Great, right. You have that duality, Kristen, in that not only are you a Vice President of Medical Affairs at Afaxys, but that you also maintain your clinic population. So really, really appreciate that dual perspective that you bring. As I mentioned today, we're going to talk about the role of vaginal microbiome in VD, updated ACOG partner treatment recommendations, and potential new therapies in development for BV that might be on the horizon. So, Dr. Cohen, I'd like to start with a level-setting question for you. So, you've researched and published such a great deal within the vaginal microbiome arena. Could you share with our listeners, maybe from a very high-level perspective, why the vaginal microbiome and vaginal dysbiosis is linked with bacterial vaginosis and its sequelae, like increased risk of other STIs, HIV, and preterm birth? And understanding that this could be a seminar that goes on for at least a semester, ask you to just give a high-level thoughts and perspectives on that, please.
Yeah, I mean, I think the terminology of vaginal dysbiosis is relatively new, maybe a decade or so. I think I first heard the terminology at one of the STI conferences, and maybe Jeannie Marazzo, who's well known in our field, mentioned it, and she's done a lot of research around BV, also was the director of NIAID for a period of time. So I think we have to understand the terminology I usually use is, and there's different terminology, is optimal vaginal microbiome. I stay away from the word healthy, although I sometimes wander into that. And then I don't use the term normal because I'm not sure what normal is. But essentially, optimal vaginal microbiome, and I think most experts would agree, is essentially dominated by a few species of lactobacillus. And these include Lactobacillus crispatus, Jensenii, Gasseri as the main ones. The one that it probably does not include, at least in my mind, is Lactobacillus inners. So what differentiates the 3 species that I mentioned earlier from inners is producing high amounts of hydrogen peroxide, which is thought to help to resist infection by bacterial and viral STIs. Now, we also have to understand, and I think it's fascinating, and I haven't seen this in a book, and maybe I haven't read your book. I'm intrigued now, but essentially humans, to our knowledge, are the only species that have a dominant vaginal microbiome comprised of lactobacillus. We have co-evolved. Why have humans co-evolved with lactobacillus and other species, even other primate species, have evolved without lactobacillus? And you think about what lactobacilli are doing, and when I say it's dominant, usually in a woman with optimal vaginal microbiome, about 90% of the bacteria found in the vagina will be lactobacillus, and they usually tend to be a single strain of whichever species of lactobacillus is dominant for that person. And I believe that that lactobacillus, of course, it's a symbiotic relationship. They're self-serving. They're trying to survive and propagate within the vagina, but also they are reducing the risk of, or they're improving the outcomes related to birth, because that's important for the human species to survive. So reducing the risk of adverse pregnancy outcomes, including preterm birth, and then also reducing the risk of sexually transmitted infections, gonorrhea, chlamydia, which we know directly relate to increased risk of infertility. So again, coevolution of lactobacillus, these optimal lactobacillus species, with humans have essentially led to our ability to survive and continue as a species. And we've also helped them because they can't survive without us either. I didn't mention with BV. So BV essentially is the lack of the optimal vaginal microbiome, the lack of the lactobacillus, right? And then what happens is the overgrowth with a mixture of bacteria which don't require oxygen called anaerobic bacteria, and then usually facultative aerobes, which some are found in the gut and others are not. So essentially it's a replacement of the vaginal microbiome with those organisms. And then the other important point too is that the vast majority of women with BV are asymptomatic. And why is that important? Well, the risk of sequelae, whether it be STI acquisition, transmission, HIV, preterm birth, I do not believe there's any evidence to say that whether a woman is symptomatic or asymptomatic, that alters her risk. Essentially, if she has BV, she has an altered risk of those conditions.
Okay, great. Thank you. And then, Dr. Park, also a level set question. We're asking these big questions up front, and then we can dive into the more practical nuances of the discussion. So, with the understanding that this has been an ongoing and active discourse for many years, and we only have 30 minutes, is VV an STI? And to what extent might new data and updated ACOG practice guidelines potentially change the thinking around this?
That is such a great question, very hot button question, right? And I will say, just to dovetail on some of the things that Craig has been saying, that I've always said that BV is sexually associated because we really don't see it in folks who are sexually inexperienced. But I want to explain also why BV is not a classic STI in the same way that we think about chlamydia. And, Craig summarized it nicely in the fact that folks can have an optimal microbiome dominated by these really good lactobacillus species. But there's this sort of continuum, right? Because you can also have like a slightly suboptimal microbiome and not maybe have frank BV if you have like a lactobacillus inners sort of predominant. And then you can have frank, what we call like dysbiosis, right? Where you have like this huge overgrowth of anaerobes. And so some folks are just existing like that after having been sexually experienced. And people can trigger episodes of BV completely unrelated to, a new sexual partner or sexual activity. So if someone's got a state that is suboptimal, and then, for example, their pH balance is thrown off for other reasons, they can actually get tipped over into frank symptomatic BV, for example. So you don't have to have sexual contact to have an episode of BV. But the thing that I want to sort of emphasize for listeners when we're doing counseling with patients is that the reason I don't want to say that BV is definitely an STI, even though absolutely these bacteria can be sexually, transmitted, is that I don't want folks to think that if they're diagnosed with BV, then that implies, for example, that their partner has been unfaithful or there's infidelity going on. Because when an STI such as chlamydia or gonorrhea enters a relationship, typically that can mean that someone had sexual contact if you are supposedly in a monogamous relationship. And so therefore with BV, we want to think about it a little bit differently. It can be sexually transmitted, some of these bacteria, and can cause symptoms in folks, but it doesn't have to be, the condition doesn't have to be sexually transmitted all the time.
Great. Thank you.
Add a little bit to that. And again, we could talk for a few hours on this, but for about a decade or so, I've been talking about what I call the genital tract microbiome. So not just, of course, there's the female genital tract microbiome and a male and so forth. And we know actually from Jeannie's sentinel work up in Seattle that we know that women have sex with women and share microbiome depending on their sexual practices. But we also know that about men and women in heterosexual relationships. And specifically, there's been some really interesting work out of Uganda with men who have multiple wives. And there's a real concordance between, assuming the man's having sex with multiple wives within the same time period, that there's a real concordance between the vaginal microbiome. So how is that? It's because the penis is a fomite, essentially, and there is a microbiome on the penis. And it also, and we'll get into this more when we talk about the guidelines and the Australian trial, the male genital microbiome differs depending on if the male is circumcised or not. And the majority of the men in the Australian trial, 80% were uncircumcised, where in the U.S. population, about 80% of men are circumcised.
And Craig, just to dovetail in that, for women patients, for example, who've mentioned that they have multiple male partners, sometimes they will say, when we're talking about shared genital microbiome, I only get BV when I have sex with this particular person. So I wonder if it's something about that person's microbiome, right? The shared genital microbiome that's in getting that person, in trouble with BV. So the penises are causing trouble once again.
Thank you. Great dialogue. Okay, so based on the multi-center study of partner treatment conducted in Australia, the StepUp trial, love the name of that, which we discussed in our last podcast, ACOG recently developed a clinical practice update based on the results to provide new guidance on the use of concurrent sexual partner therapy to prevent bacterial vaginosis recurrence. So, Dr. Park, could you please share with our listeners a summary of this new guidance?
Yeah, and I would actually love to hear Craig's thoughts on this afterwards, because the guidance has some subtleties in the language that I think people who write guidelines understand, but I feel like when clinicians read this, I feel like they're going to get a little bit of a blank check in terms of BV partner treatment. So just to summarize, and I'll actually share some of the exact language. Basically ACOG says that concurrent sexual partner therapy, the languages should be considered, right, for male sexual partners when someone has recurrent bacterial vaginosis. Then they go on to say, shared decision-making should be used for other types of patients, and that includes folks who are same-sex partners, for example, women who have sex with women. And then also to, use shared decision-making for someone who has a first episode of symptomatic bacterial vaginosis. And in the Australian study, I want to point out that actually most of the people had recurrent BV, and there were not as many people who were there just for their first episode. So the impression that I got from these guidelines were that I think folks are definitely going to run away with this and start really using partner treatment very liberally. Because even though the word consider is in the clinical recommendations, when you use the word should, I think clinicians think, well, if I should consider it, then maybe I should offer it. And so, in the CDC guidelines, since I work on a lot of guidelines, when we say the word should, we're strongly recommending that. And when people say consider, it means, think about it. But I think when ACOG says should be considered, I think folks will certainly use it. And I just want to point out, Craig already mentioned that we don't really know how it's going to work in a typical U.S. population of people that have BV, many of whom may have concurrent sexual partners, as well as folks who are presenting, for example, for the first time with BV, and a lot of folks who are circumcised. We don't really know. There's huge differences in the microbiome and no idea if it'll work as well.
Great. Thank you. That's really helpful. Dr. Cohen, would you like to comment on anything with regards to that recommendation?
I'll give you my top line thoughts is that this was premature. Again, first of all, who bases guidelines on a single study? Predominantly enrolled participants from a single clinical site in a population that is very different than the American population.
Very different.
In race, ethnicity, but also, as I mentioned, very importantly, circumcision status. They were underpowered to demonstrate significant benefit of the intervention with the men who were circumcised. And that's important because the subperficial space, the space under the foreskin, harbors a very high number of bacteria. Of course, that's partially dependent on the hygiene of the man, how often, how frequently, how he washes his space and keeps his penis clean. But so we really don't have information on that. And the other part is, what do couples think about? What do women think about this? What do men think about this? What do couples think about this? And how is this going to be implemented? You can have the world's best intervention, and if it's not acceptable within that population, no one's going to use it, and it's not going to have any impact. So I think before this gets rolled out, before ACOG has guidelines, there needs to be these other evaluations. First of all, another clinical trial in our population, multi-site, truly multi-site. And then also we need to understand acceptability in various settings. And then it's not similar to like treating a partner for a traditional STI. This is more complicated than that. So how do you implement that?
Yeah, and I think following a clinical trial and like a demonstration project with a strong qualitative component, you know what I mean, where they do interviews, focus groups with U.S. populations.
Completely agree.
Mm-hmm.
I'd like to ask each of you, based on this, are you implementing, this guidance, at all within your clinical practice? And Dr. Park, maybe you could go first, and then Dr. Khan, be curious, also your perspectives.
I sent out the ACOG guidance so we could discuss it at a clinician meeting, because right now, on a very limited basis, I've dipped my toe in with certain people who better fit, I think, the description of the folks that were actually in this study. And a couple of our nurse practitioners have tried the same. We have not on a large scale implemented this in the clinic. And so, I'm a little bit hesitant to say we should just go ahead and do this as a blanket recommendation for all the reasons that Craig said. But I have sort of dipped my toe into the waters, and I will say that there are some challenges within just our EPIC medical record. For example, you cannot order clindamycin 2% cream for someone whose sex in the EPIC chart reads male. So we're going to have to work with our IT folks to change that. So just little things that make a big difference.
Okay, great. Thank you. And Dr. Cohen, how about within your clinical practice?
So since the guidelines came out, ACOG guidelines came out, I've been out of the country. So I haven't had a chance to interact with anybody about this since the guidelines have come out.
Okay, great. Thank you. And Dr. Park, you curious what the receptivity has been? So for, patients and also, their partner receptivity for those where you've had those discussions.
Yeah, so I had a patient who came in with their partner, and both of them were, highly motivated because, they were in a monogamous relationship and were not just casual partners. So they were very receptive to the idea because she had had multiple recurrences of BV, and both of them were sort of fed up with the whole thing. So other cases, the woman has been very receptive, but the male partner is not there. So I have no idea how that's received. And I think what's interesting to mention about the Australian study is, only 2/3 of the male partners actually were able to adhere to the regimen, in the sense that people did it incorrectly. Some people didn't put the cream on at the same time, or didn't, forgot the cream and only did the orals. And so women have said, I'm not sure if my partner's receptive to the idea. And also, I think it's really clear that partners are going to need some sort of support. And so I think that really we don't know truly, which is why I mentioned a demonstration project, to know how well this is going to sort of be taken up by the community.
Great, thank you. And Dr. Cohen, you had mentioned during one of our, earlier planning discussions that there have been subsequent, responses to this practice guideline. And I wondered if you could, share any additional perspective on these recommendations and implementation.
Yeah, I've been having conversations with various colleagues about this. We've even penned an editorial that's pending, basically outlining our arguments for why we think it's premature to move ahead with this as a routine guideline based on arguments I already expressed. I don't think the group in Australia has published the results of the microbiome, because I'm very interested to see what the impacts are of the intervention, especially on the male microbiome, but also the female genital microbiome. I mention this because Elizabeth Bakusi and I, along with King Holmes, did what we called the weenie wipe study. So what was this? So essentially it was looking at a similar hypothesis of the role of the male partner genital microbiome on recurrence of BV. The intervention was different. You had men apply, and don't cringe at this, but we had men apply Purell on their penis.
I remember this study.
It had a cooling effect, shall we say, a cooling effect. It wasn't all that bad, but we had a control group as well. Oh, I should mention also in Kenya, in that population, about 80% of men are circumcised, similar to the U.S. And in that study, again, very different interventions. I'm not trying to equate them, but in that study, we actually saw a trend towards increased recurrence of BV in the intervention arm comparison to the control. So initially, what we saw was that the men who used the product, about 1 hour later, we saw a reduction in bacterial load. But at 4 hours, and especially at 24 hours, we saw a tremendous rebound. So, and that's not dissimilar to what you see with the skin microbiome when you use Purell on your hands as well. Initially, there's a reduction in load, but then soon thereafter, there's a rebound. So I think we have to be a little bit careful in how we use these sorts of products and really on definitive proof before we move forward.
Okay. So then moving on, Dr. Feldman, what would you say are both the opportunities and maybe also the potential barriers for partner treatment?
I think having a new treatment modality in and of itself, has some value because some patients really are extremely frustrated from bacterial vaginosis as well as their partners. But I think in practical terms, there can be some significant barriers to treatment when I think about translating the science into the clinic. So thinking about it from the perspective of our variety of public health clinics that we serve, for example, if the patient's partner is also a patient at the same federally qualified health center, it probably would not be very difficult to facilitate treatment for him in that circumstance. But if the patient with BV is getting her care at a high Medicaid gynecology private practice, for example, then caring for her partner might be more challenging. And what I've found personally over the years talking with patients is that many young men don't have an established relationship with a clinician anyway. So we may be starting from scratch.
Great. Thank you. It's interesting to hear about, experiences and how you navigate within that non-academic private clinical practice setting, in addition to, research settings and academia. So then, Dr. Feldman, you get to have one of the big questions as well. Can you explain to our listeners if the CDC has classified BV as an STI?
A great question. So if you look at the 2021 STI treatment guidelines on the CDC website, BV is listed as an infection in that section of the site. But if you read the body of the documents, they don't actually classify it as an STI, referencing back to what Ina was saying earlier. And the patient education part of the site doesn't state that it's an STI in the way that the patient education for chlamydia does, for example. And I certainly don't fault the CDC for taking this approach, but I can see how that could contribute to some of the confusion about whether or not it is an STI as well. So the other thing I wanted to touch on briefly, Beth, I've been thinking about this from my point of view as to how I might be able to translate this into my practice. And so the ACOG guidance did state that clinicians could investigate their, local regulations and institutional policies to determine whether or not they could establish a patient-physician relationship with a male. So I think that's one option. Another option is thinking about getting in touch with local family practices close by such that I can refer male partners to those practices and they'll already sort of know what I have in mind and what these guidances are. Because I think the worst case scenario is a patient showing up at another provider and saying, hey, my partner said to come in and get treated for BV, and that clinician knowing nothing about this discussion that we're having today. Another thing I've thought about is just going old school and printing out the ACOG clinical practice update to hand to the patient, to hand to her partner, and share with their own provider. So I've always been really interested in how we can, in practice, do some of the things that we're talking about in academic and research settings. And, none of these are particularly high-tech or efficient, but they're the ways that I have been thinking about how I can incorporate them into my practice.
And then can I just add, Kristen, so one thing that the New York City Department of Health, who runs many STI clinics or sexual health clinics in New York City, they just added it to their website and they said, if you are a male who has a female partner with BV, we are now treating those folks and you can come in for services. So they're literally advertising it on their website.
And that's a great idea too.
Thank you for those perspectives. So we're coming closer to the close of our session, and I would like to turn an eye towards the future. So Dr. Cohen, you've been involved in the arena of BV treatment, specifically the prevention of recurrent BV after treatment with antibiotics. And I wondered, could you share with our listeners the mechanics of this type of diagnosis and treatment, and maybe how it has evolved over time?
So as I mentioned earlier, I mean, the goal in my mind is, of course, alleviating the people who are symptomatic, the symptoms of BV. Those who are asymptomatic, it's essentially helping the patient to develop an optimized vaginal microbiome, which in part has two components, right? So one is we need to eliminate the bacteria associated with BV, so predominantly anaerobic bacteria. And so our predominant treatment is metronidazole, either topical or vaginal or oral, depending on patient preference. And then what's missing, and the same thing, what's missing from the male treatment is then the replenishment with the optimized lactobacillus. A lot of my work has been regarding the development of live biotherapeutics, and we've had some very positive results from a phase 2B trial that was published. But to be honest, the company's not been able to raise the resources to do the phase 3 trial, which then is a requirement of the FDA in order to get licensure so we can bring this product to the market. And I also it's apples and oranges, but the recurrence rate in the male treatment trial in the treated arm is 30%. So 30% of the participants of the women in the trial still developed recurrence. The recurrence rate in our phase 2B trial of Lactin-V, that's a Lactobacillus crispatus, was 30%. I think it would be intriguing to do a combination. What would happen if we used antibiotics, treated male partners when that's appropriate, and use a live biotherapeutic comprised of Lactobacillus crispatus? Maybe we can get that recurrence rate down to 10%. So I just think that when we're thinking of treatment, we really need to rely on combination of antibiotics, potentially treatment of the male partner to eliminate kind of reinfection, if you will, or whatever's transpired. We'll know more when we see the microbiome data from that study, and then the replenishment of the optimized lactobacillus.
And Craig, I couldn't agree with you more because, BV is multifactorial. It's different than gonorrhea. Gonorrhea, the bacteria is there, you have the infection or you don't. And in this case, it's both the optimal microbiome and getting rid of the anaerobes. And so, yes, in the perfect world, it seems like there would be synergy. That would be so exciting if that type of clinical trial could happen.
Well, we need a licensed product is what we need. I like live biotherapeutics unfortunately, some companies have been short-circuiting the FDA approval process and getting their probiotic and differentiating from a live biotherapeutic approved as a cosmetic.
Right.
So they're doing one small trial, not very well done, and then moving forward with their product as a cosmetic, similar to douching products.
Right.
Very little safety and very little efficacy data.
Right. Or quality control regulation.
Very little everything.
Yeah, very little everything.
Yeah. But to do it properly requires a lot of resources that is difficult to procure. Lack of investment in women's health, sexual reproductive health. I mean, we'll keep on coming back to this. But it's
hopefully that's starting to change a little bit.
Issue.
Yeah.
Yeah. Huge issue.
Without question. So I'd like to kind of, in wrapping up here, ask, each of you if there's resources, beyond what we have discussed here that you'd like to recommend, to our listeners from each of your perspective. And maybe, Dr. Parr, if we could start with your perspectives about additional resources that might be available.
Sure. I wanted listeners to, draw their attention to Melbourne Sexual Health Center's website called BV in Focus. For those who are thinking about implementing this, there's decision-making tools for clinicians, there's videos, and there's information for both patients and clinicians on that site. So it's Melbourne Sexual Health Center. That was the center that actually did the randomized controlled trial. So this will be in the show notes, as well as a link to instructions for male partner treatment. They were done by the New York City Department of Health and then translated into 15 languages and are now living on the Australian Melbourne Sexual Health site. So our training center is hosting a webinar on December 18th with the senior author of that Australian study, Kat Bradshaw. who's going to be talking about some of the practical implementation issues with male partner treatment. And so we'll include a link to register in the show notes as well.
That's great. Thank you. That resource will be tremendously helpful, I'm sure, our listeners. Great. Thank you. So for our audience, we'll have all of the resources that were discussed today in the show notes for each of you. Our time has really flown by. I'm sure that the audience has found the discussion to be really tremendously helpful. We understand how demanding everyone's schedules is, both for our presenters and experts as well as the audience. So thanks for joining us today on this episode of Afaxys Candid Conversations in Public Health. Just to let you know, next month we'll be featuring an episode with Dr. Sarah Ann Burnett and Dr. Donna Adams-Pickett, where we'll be discussing contraceptive myths and disinformation with some practical tips for HCPs who are navigating the contraceptive conversations in this age of very active social media. So I'd like to thank once again our expert guests for today, and as always, Dr. Kristen Feldman, and thank you so very much for your time.
Thanks for listening to Afaxys Candid Conversations in Public Health. To learn more about our mission and resources for clinicians, visit afaxys.com. Don't forget to follow or subscribe so you never miss an episode, and we'll see you next time.